Hello, everybody. Thank you for inviting me, Madeleine, 24. So I am going to share my screen and see if I can get my presentation up. Okay. I hope you can see this, everybody. So my name's Lorraine. I am a consultant advanced nurse practitioner. I work at the Christie Hospital in Greater Manchester, and I am doing a bit of a whistle-stop tour of a couple of pieces of work I've been involved in. In the bulk of it will be around my PhD, but hopefully my presentation will show around the barriers and facilitators of cancer patients entering clinical trials across ethnic diverse groups, and then really go into the aims of my study, which hopefully is going to address some of the barriers that were identified. So, see if we can get the next slide. Okay, so Greater Manchester. As many of you are aware, it's the second largest conurbation in the UK. There's almost 3 million ethnically diverse population. Almost 30% of residents are from an ethnic minority, and that was from the 2021 census. A fifth of our population in Greater Manchester identify themselves as Asian British, or Asian Welsh, and Muslim is the second largest religion, with approximately 22% describing themselves as Muslim. So 1 in 3 residents in the city of Manchester are actually born outside the UK, and staggeringly, there is reported to be about 94 languages, which really is a phenomenon statistic, really. Unfortunately, though, in Greater Manchester, 30% of recorded deaths are due to cancer, and that's 10% higher than the rest of the UK. Now, these were based on the Office of National Statistics a number of years ago. So things have improved slightly, but we are still, unfortunately, in Greater Manchester, one of the highest cities with the highest reported number of cancer deaths. I think across the board, though, we know that there are inequalities in cancer. Around 20,000 extra cancer cases per year are reported in more deprived areas of the UK. Most deprived areas have the highest premature mortality rates, and therefore poorer outcomes from cancer. Women of African origin are disproportionately diagnosed with late stage subtypes of breast cancer, in particular triple negative breast cancer, which is probably one of the most severe forms of breast cancer, with a staggering mortality rate of 42% being diagnosed higher compared to white women. Across the whole cancer trajectory, cancer screening uptake is lower in marginalised groups. We know, there was an article published in The Guardian in 2022 that Black, minority and ethnic groups were reported to wait between 9 and 11% longer for a cancer diagnosis, which is a staggering kind of statistic. We know that, again, Black, minority, ethnic groups are well underrepresented within clinical trials. I guess when we talk about inequalities, it's very complex. We know it's such a broad kind of spectrum of various determinants of health, which can obviously play a significant part in people's, obviously, well-being and health. Interestingly, I guess with the increase in digital technology, there is kind of a theory that this is just adding another potential inequality for some of the population who have no access to laptops, smartphones, etc. And I guess my background, I work in breast oncology, but I've also worked in clinical research for a long time now. And when I first started working as an advanced clinical practitioner at in the early phase trials team at the Christie, I guess anecdotally we saw the same patients coming from the same areas, Greater Manchester, very few ethnic minority patients. So I undertook some audits, and this was back in 2012. We only had 99 referrals from across Greater Manchester into our early phase trials team. Like I say, it was a very specialised unit, and it was a retrospective data collection. And from that data, it's quite obvious that the majority of patients referred were white Caucasian. Unfortunately, Asian and Black, they're grouped in kind of very kind of big, narrow categories there. But we knew that there was very few patients that were Black or reported as Asian. I repeated the audit again in 2016. We had nearly 260 patients referred at that point. Unfortunately, we see even nowadays, the reporting of demographic data is very poor. 36% of the data that I was looking at did not report ethnicity. So I guess it was very difficult to really quantify kind of the disparities in referrals. But again, we knew that, the majority were white Caucasian. There were, again, people referred from certain geographical areas in Greater Manchester. There were certain clinical teams referring from different trusts around Greater Manchester and fewer from other teams. And again, that's not a criticism. There's lots of reasons for that. But it was just it did show, obviously, that I guess people in regions and communities where the burden of need is greatest are very much underserved by research. We know that clinical research in the UK is absolutely pivotal and contributes to global public health improvements. Everything we do in healthcare is based on research. We know that obviously we have to, look for improvements in screening, prevention, diagnosis, and treatments, and all of those are kind of put through clinical trials, clinical research. We need that diverse representation to enter our clinical trials to really understand the biological variations that can affect cancer occurrence, experience, and effectiveness of treatments. I think, obviously, most importantly, there's an ethical and moral justice, that equal opportunities in accessing treatment options in order to, receive some of the really, advanced medicines and treatments is absolutely pivotal, and, it has to be done fairly to benefit all people affected by cancer. There's, reports that greater participation obviously means that trials can be conducted more rapidly and efficiently. And it's reported also that research hospitals deliver high quality of care and better outcomes. And there's also, studies out there showing that actually patients taking part in clinical research, they do feel it's a very positive experience. In kind of both physical and emotional and psychological. So, that's just a bit about the background of the work I've been doing. And I was very fortunate I got funding to do a PhD. And as part of that PhD, I wanted to really kind of look at the peer-reviewed, published literature out there that really kind of looks at the barriers and enablers to participation in cancer clinical trials for ethnic diverse communities. And to look and really probably understand the complexity and the multifaceted elements that do contribute to inequalities in cancer trial participation amongst patients. So the objectives were really to, like I say, conduct it as a qualitative systematic review, really like looking at papers that were looking into patients' perceptions and experiences of the barriers and enablers across any ethnic diverse group, but also to include the views and perceptions of healthcare professionals, healthcare leaders, and also patients' family members as well. So it was a comprehensive scoping of the literature, and initially the literature was scoped to refine the research question and develop the search terms, and then the inclusion criteria was qualitative studies published in English over a 10-year period. Any patient aged 18 or over with any cancer diagnosis and any stage and any ethnic group. And the qualitative papers had to really be looking at the barriers and enablers that affect patients' decision-making and participation. And like I say, I included papers that will include healthcare professionals, healthcare leaders, and those carers or immediate family members of patients with cancer. Many of you have probably seen this, the classic Prisma diagram of the screening process. So from a total number of 1,123 papers, by the time I removed the duplicates and by the time we excluded those that didn't meet the inclusion criteria, we were left with 17 qualitative papers. Now, out of those 17, 16 studies were conducted in the United States, one in Singapore. The most common ethnic subgroup, therefore, as you can imagine, would be African American or Black and Hispanic. Breast cancer was the most common cancer for the participants that undertook in the qualitative studies, and prostate for men. The majority of patients across the papers were age 50 plus and had an annual income of $35,000. There were many of the participants earning just over $20,000 per annum, college level education, and several unemployed across the papers. Now, 5 papers were actually published from one very large study, and that was looking at what the healthcare professionals, healthcare leaders felt were the barriers and facilitators. And they were across five National Cancer Institutes across the US. The majority of studies were actually undertaken in the NCI cancer centres across America. Now, this is quite a busy slide, but this is just some of the these are the themes that kind of came out the papers. And I tried to colour code them to see if there was any kind of similarities between what the patients reported to the patients who were more on the left 2 columns and the healthcare professionals on the right 2 columns, and to see, if there is any similarities. And as you can imagine, for the patients, the knowledge and understanding of clinical trials was a very huge theme. Many patients, their knowledge of clinical trials were through experience of either loved ones undergoing cancer treatment, a lot from advertisements on the television. Obviously, this is in America. There was a lot around their concerns about clinical trials, the perception of clinical trials, and the language that we use in research and the connotations that people associate with the language, concerns about being guinea pigs. There was a real kind of concern about therapeutic concerns. Patients would often say that, that they've got cancer diagnosis. How can you give me a placebo medication? They really didn't appreciate that many trials, they are for oncology patients, it's comparing routine with maybe a new novel agent. So that was a big thing as well. They did feel, though, that it was absolutely crucial that they were well informed, that the communication information was culturally sensitive and appropriate, very much holistic approach to care. They did mention, there's some of the challenges of having family members to look after, cost and transport, but that really didn't come out as much as what the healthcare professionals felt were the main barriers. They often said it was the cost of transport, additional trial requirements, attitudes and beliefs. Whereas that didn't come out of what the patients were saying. They did feel about the spirituality was important, the holistic approach, religion as well came through. A big thing about distrust or trust was absolutely key, and those developing relationships with clinicians. So, as you can see, there is absolutely quite a lot of different themes coming through. So it'll just represent how complex this is when you're looking at the barriers and facilitators of patients going on to cancer clinical trials. And like I say, the therapeutic concerns were really kind of coming through in the papers. The family, how they played their role in decision making, the spirituality and holistic approach, very much strong themes. However, these were not really identified when asked, when the healthcare professionals were asked what the barriers and facilitators were. Unfortunately, throughout the papers, there was this theme of very much an unconscious bias. There was kind of themes that the ethnic minorities were less likely to receive information about clinical trials. There was this perception that they are less knowledgeable, so will require more time and resources. It was felt that having language barriers and consent, that would raise problems with compliance or safety issues, so patients wouldn't be able to raise any kind of alarms that they were having any side effects. Some of the quotes here, as you can see, it's just too darn hard to try to talk to them into a clinical trial, so let's just do standard therapy. I like the quote where it says, try to talk them into a clinical trial. That's alarming, just that phrase as it is. One clinical research nurse mentioned that minority groups have been excluded from some trials. It's done under the guise of it's usually a communication issue. Another healthcare leader, I think that there's a physician bias that's subconscious. We know that if African Americans are offered clinical trials, their acceptance is just as high as any other ethnic group, which is really interesting. So my conceptual framework from reviewing the qualitative pieces of research, I try to put it in a diagraphic form, and as you can see, at the centre is the decision making and all the factors related to patients making that decision. We've got patient attitudes and beliefs as well, obviously plays a big part. We've got the healthcare professional factors, very much around the time constraints. They haven't got the sufficient training. They don't know what trials are on offer. Time was obviously an issue, and resources as well, not having any clinical research nurses to help support in clinic. And then you've got the patient-specific barriers, and then the healthcare perception of trial burden and social determinants of health, which really came in, which didn't really match what the patients were saying. The big kind of importance of interpersonal relationships. So as you can see, this was put in a diagram just to try and illustrate the various themes that came out and what the systematic review actually conceptual framework that came out. The limitations, though, of the systematic review was that the majority of literature was undertaken and published outside the UK. So, really, are the barriers, the facilitators generalisable across the ethnic groups that we have in the UK? It certainly doesn't capture the intersectionality, heterogeneity amongst ethnic groups. The majority of research, like I say, was carried out in large academic centres. So, what about the smaller trusts, the smaller centres in America, the primary care? It was interesting because the healthcare professionals, healthcare leaders in the qualitative papers were predominantly white. The oncologists and PIs were majority male. So are you getting a skewed, outlook and not an inclusive outlook from other healthcare professionals and different ethnic healthcare professionals as well, ethnic diverse healthcare professionals. It is, though, the first analytical synthesis of qualitative research that represents perceptions and views from both patients, carers, healthcare professionals, healthcare leaders. But it does highlight additional complexity to the phenomenon, and especially this kind of contradiction between what patients report as barriers and what healthcare professionals perceive as patient-reported barriers. So, like I said, the research really does not examine the intersectionality amongst ethnic groups, and it doesn't really touch too much on the religion and cultural norms and how they play a part in patients' participation in cancer trials. So, from the systematic review, it helped kind of looked at the gaps in the research and helped me formulate what do I want to do? What do I want to do to contribute to this kind of minefield? And I really want to do some kind of qualitative research, really to explore the experiences of Muslim women who have a diagnosis of breast cancer and look at how their faith, their culture influences their cancer knowledge, their understanding, their perceptions of cancer, but also the cancer treatments. And included in that is obviously cancer clinical trials, with the aim really to co-design a faith-based intervention that is engaging and accessible to really empower women to take part in breast cancer trials. So my study is, like I say, an exploratory research. It's over 3 phases. At the moment, it's just opened. It's just got REC and HRA approval. So I am starting to recruit ladies with a history of breast cancer and undertaking semi-structured interviews. And I need to recruit between 12 and 15 women with the aim of 8 family members as well. That's immediate family members. Phase 2 is kind of concurrent, so distribution online survey to healthcare professionals that work within breast oncology. They don't have to be involved in research, but I really want to look at their experience of what happens on the clinical floor, looking at their experience of religious and cultural norms influencing patients' perception of cancer, their treatment, whether they go into clinical trials or want to know about clinical trials, and also any initiatives that have been underway or are underway in Greater Manchester that support participation of patients across ethnic groups in clinical trials. And then using phase 1, phase 2 to then feed into and structure phase 3, which will be a community-centred participatory series of workshops based on the World Cafe method, which is like what it says. It's a cafe feel where there'll be groups, ladies around smaller tables with, refreshments, with food, have social gathering to include family members as well, and a couple of healthcare professionals to really then come together and co-design this faith-based intervention that is about what they want, what they need. It's not about what I think or what the healthcare professionals feel. It's really, to develop it and to co-design it. So the inclusion criteria for phase 1 and 3 is, like I say, it's women with any type, stage of breast cancer. They can be either receiving treatment or have completed treatment. They can invite their family members to take part. And when I say immediate family members or primary care, it's spouse, child, sister, brother, father, mother, and grandparent. They can be male or female, self-reported as Muslim, 18 and over, and obviously willing to provide consent. I think one of the main kind of one of the main things about this research that I'm really passionate about is recruiting research ambassadors. And they will be female, and they don't need to have a history of cancer, but they need to be of Muslim faith. And it's really as a support mechanism for the participants, but also to have that kind of insight into the culture and to help review documents and to ensure that, the information we give to ladies during the interview and the questions that we use the language is meaningful and culturally appropriate. And absolutely paramount is to include them in all phases of the research, but also when we are analysing the data and looking at the transcripts and really making sure that we're not missing any of those kind of cues or areas that could potentially be lost in translation, and pick up on the nuances that potentially I could miss. So I think this is going to be really important for this study. The recruitment will be via purposive sampling and also snowball sampling. So it'll be women attending for treatment or follow-up at participating breast oncology clinics. So it'll be Christie main site. We've got Christie at sites all over Greater Manchester. We've also got the Manchester Foundation Trust in North Manchester, which the team there are keen to help recruit as well, which would be brilliant. Since starting the PhD, I started as part-time, now full-time, but I've been building relationships, collaborations with various grassroots community groups, charities, to raise the awareness about what inequalities in research mean, what I found over the years, the importance that we need to have true representation across all our patients, the benefits of research, but also, the things that research isn't. And it's really to make sure that people are offered the chance to take part and that are informed to be empowered to make that decision. And that's what I am, speaking to various groups around Greater Manchester, so they get to know me. There's been various cancer support groups that have put on cancer awareness events, which I've attended to support as well. So it's a two-way process. And I think that should be continual, regardless of the PhD. As a healthcare professional, I intend to continue those collaboration. And I've stressed if there's anything I can do to support any of their cancer events, then obviously I am there as a source of support. So there'll be the two areas to help with recruitment. So the interviews, like I say, with phase 1, the participants will fill in a demographic questionnaire, capturing some demographic data and personal characteristics. The participants can have their interview in person at a place that is of their choice, or via telephone or via virtual means. The semi-structured interview topic guide has been developed with support from representatives from the Muslim faith, from ladies of Muslim background, and attention, like I said, has been around literacy and the cultural sensitivity of the questions that I ask. I think when we use interpreters, or hopefully the research ambassadors, that they will be obviously well informed about the study, and there'll be a session, a briefing session before, and also the interpreters will be allowed to have some time with the participants as well prior to the interview, just to build a bit of rapport. And it's really important that that participants will not be expected to travel, that the interviews can be carried out in any place that is comfortable for the participant. Like I say, the concurrent phase 2 will be underway. The online survey is being distributed via Qualtrics, which is a University of Manchester platform. And the survey is being sent out with various gatekeepers, including research and innovation departments across the NHS Trust, Cancer Research UK, UCONS, Greater Manchester Cancer Network, and Pathway Boards. So they've all mentioned that they will help be the kind of gatekeepers, which is brilliant. And it is for all healthcare professionals involved in the care of a patient with breast cancer in the Northwest. The fact that when they complete the questionnaire, obviously that they're giving consent for their data to be used for the purposes described in the patient information or the participant information sheet. And then once phase 1 and phase 2 are completed, then phase 1 will go through a thematic analysis using the transcribed data. We'll be using NVivo to organise the codes and themes. And like I said, the research ambassador will play a key role in the analysis and interpretation of the results. Alongside phase 2, there'll be thematic analysis of the open-ended questions and descriptive statistics with the quantitative data. And then using the results from phase 1, phase 2 will be then kind of used to bring together and facilitate the structure for phase 3, which will be the co-design workshops. And the workshops will be, I really would like the workshops to be kind of using other means of reporting outcomes. So the research that was done by Kotzer et al. In 2023, they co-designed, again, with Muslim women of faith-based interventions, looking at improving breast cancer screening uptake. And they had the feedback in more kind of pictorial kind of means, which I think is, what I would like to do, as well as written form. I think it's quite powerful to use illustrations to portray patients' perceptions, feelings, and also to describe what they feel is important to them when we talk about inequalities in cancer clinical trials and obviously how can we overcome them. So that will be obviously at phase 3. So again, I know that's a bit of a whistle-stop tour of my kind of work so far, but hopefully my details will be shared. And please, if anybody wants to get in contact with me, I would love to hear from you. If anybody's doing similar work around Greater Manchester, then please get in contact with me. So thank you for that, and I wish you all a lovely evening, and take care.